Hello and welcome back to Inside Health Innovation Podcast, where we go and find those key innovators behind healthcare's innovation boom. And today, I'm delighted to be joined by Dr. Nayan Kalnad, the co-founder of Avegen, who builds digital tools to truly empower patients and also help improve their care. We discuss the Swiss Army knife approach to building digital health solutions, the challenges with condition-specific digital health apps, the troubles faced when doing EPR integrations, and also how to manage a business relationship effectively with the NHS. Let's get started. Welcome, Nayan, to Inside Health Innovation Podcast.
Thank you. It's great to be here and thank you for the invitation.
Yeah, not at all. We're so excited to hear about your Swiss Army knife product today. Really looking forward to hearing all about it. First and foremost, thank you for giving us your time and talking to us all about Avegen.
Yeah, it's fantastic to be here, I think, because we really need to find a way to get the news out. So It's good to be talking to people about what we're doing at Avegen.
Oh, brilliant. Well, we'll definitely get that out of you today. So let's start with the question that if you've heard this podcast already, you'll know I always start with, what does the word innovation mean to you?
I was trying to think about this because we use innovation so often that you actually don't think what innovation means to me as an individual. And I think my conclusion is that for me, innovation is what we do to enable individuals to lead much better lives. So that means if you find a way to transcribe what we are talking automatically, that means you and I have more time to do, maybe spend time with family, spend time with friends. So for me, I think innovation is all about developments that improve human lives.
Yeah, that's a really nice way to look at it. Thank you for sharing that. So let's talk about your journey to where you are today. So let's start at the beginning. You studied medicine, but then you went into drug development. What inspired that transition for you?
So I think the transition to drug development was mainly because I was extremely interested in pharmacology while I was in medical school. So I wanted to sort of understand how or play a role in how drugs are brought to patients. And luckily for me, I think even though it was sort of like a non-traditional move for most clinicians in India at that point of time, large pharmaceutical companies were doing more and more drug development work. So I got an opportunity to join a large multinational company where I think we were trying to do clinical trials in India maybe for the first time.
Wow.
So it gave me that sort of flavor of how technology innovations come to the market, in that case, medicine. So that was the primary reasons for switching out of clinical to research and development. So.
And how did that go for you? Did you enjoy what you learned in that space?
Yeah, in short, yes, because my initial plan was just to do it for a couple of years and then go get a master's in pharmacology or do a doctoral work in pharmacology. But I think just working for a business sort of gave me the exposure to what is possible at a global scale and what is possible when a bunch of people can get together and get behind an innovation. Yeah. So I decided to actually not do my master's in pharmacology, and I spent a good 5-6 years just doing drug development or managing clinical trials in large pharmaceutical companies. So absolutely.
Yeah, how interesting. And you talked about obviously this role that you were in was in India. Yeah. So your journey has brought you from India to now the UK, which is obviously where you are as of today. So tell me what sort of made you make that move?
I'd love to say that it was a professional move, but it wasn't, I guess. Like most people, I don't know if it's like most people, but my wife decided to, that time we were dating, so she decided to do a master's and PhD in UK.
Right.
So it was either, break up or you move.
Yes.
So I decided to make the choice that
you followed her.
I followed her
here.
Essentially.
All for love.
Yeah, all for love.
Brilliant. And so you followed her here, and were you still working in pharmaceuticals at the time then?
So what was what was good for me was it also sort of fitted in with how my professional career was progressing. So I got an opportunity to lead drug development at a global level. So the company that I was working for wanted me to move from India to UK.
Perfect.
So in some sense, I think the stars aligned quite well. And during that time, I was also interested to see how innovations can scale, but less from a R&D perspective, but more from a commercial perspective. So I wanted to get some understanding of business management or business administration. So I got into London Business School here. So that was a good 2 years of sort of just understanding what it takes to build and scale a business.
Yeah, no, definitely. That's fantastic. I mean, London Business School is amazing for that. And now that you've kind of worked across the pond, as it were, in India and the UK, do you find there to be any difference in how the two countries approach healthcare innovation or drug development, for that matter?
In short, yes. I think there are fundamental differences between how I think healthcare is approached in UK and healthcare is approached in India. In India, healthcare is primarily out of pocket. So I think even today, I think 70 to 80% of spend is self-pay. So where the patient actually pays for their own drugs, diagnosis, procedures, etc., etc. While here, obviously, it is free at point of care. I think there are pros and cons to both models. And in India, what I find is that because patients pay, they have a lot of choice, and in some sense, the money truly follows the patient. So if we come out with an innovation, if it is really good, then it's actually much easier to scale those innovations. The counter or the downside of that is obviously it really depends on the ability of the patients to pay or the family to pay. So you have a lot more disparity between the well off and the not so well off, which we don't see here. I think the downside of I think the UK or the model here is that the money truly does not follow the patient, even though there is probably a drive to figure out how patients can influence the choices that is made on their behalf. But in our experience, I think the UK system is a lot more about cost containment, and patients have a say, but not as much of a say as you would see relative to India. So I think as a company which is trying to operate into very fundamentally very different markets, I think it poses different challenges. Exactly.
I guess your message needs to be very different in terms of the benefits your solutions can generate for those two different markets.
Absolutely.
What happened in your career that led you to become an entrepreneur? So you're sort of following this lovely journey all the way to the UK for love. You're doing well in a global pharmaceutical role. What made you decide, actually, do you know what? I want to quit all of this and I want to start all by myself in an entrepreneurial setup.
I think so when I reflect back on my career, I think a lot of the times once you go through the process, you reflect and then you sort of realize who you are and what you are. So if I look back on my own journey, I think that I'm more inclined to be somebody who wants to do new things or who wants to figure out a new way of doing things, which is fundamentally, I think, what most entrepreneurs are, because you look at something and say, okay, there is a better way to do this. Because I think I started trying to I was selling when I was in grade 6, when I was 12. So when I look back, I'm like, okay, that is who I am as a person. And even in both the large pharmaceutical companies that I worked in, the opportunity that I got was to set up a new team which is doing clinical trials, which is not as common now as it was not as common then as it is now. So intrinsically, I think I'm an entrepreneur. So I think for me, the job that I hated the most was where it was very clear what needed to be done, and it was just about how good you are at it. It was not about figuring.
You almost didn't like that structure
Exactly.
and the predictability of it.
I just need to know how to move this from here to here as well as I can.
Yeah.
So I think there is that intrinsic nature that I want to take a problem and figure out an answer to it. So, and then working in large companies, or at least in pharmaceutical companies, what I was interested in was that how does one scale good quality healthcare, and digital is I think an excellent tool to scale. But it's not core to pharma. Where I worked, the core business was how can we get new, safe, efficacious medicines into the market. So that was innovation that the company was working on. So there was that divergence. And then, so I had only two options. Either I join a company that is using digital technology to improve access to care, or set up one myself. And I took the latter route. So.
And is that because you enjoy digital innovation, you saw the scale up potential, or a bit of both?
I think it was a bit of both, but for me, I think the root, the key driver came from my own sort of personal experiences. So when I was still, I think I just graduated, one of my friends got diagnosed with type 2 diabetes, and it was quite severe, moderately severe. And then immediately his physician just prescribed loads of medicines, which is fine. But what I was telling him was that, look, you start on this, but if you do not make some fundamental alterations to your lifestyle, it's just going to get worse and worse. So I then worked with him over 3 or 4 months or so, where pretty much I reviewed his whole diet, changed it, made it. He was a baker, so clearly not a healthy diet. And then I think
that's probably the worst profession for somebody
having diabetes.
with diabetes.
And then the second one was that I looked at his activity or exercise. So pretty much got him from zero to, I think, fairly. He started getting into a routine of exercising, and also managed his stress. So over that 3 to 4 months, just working with him, what happened was we were able to reduce his glucose levels, and I think to an extent where he also did not need to take as many medicines as he had been prescribed, which was great. But that got me to thinking that he obviously pretty much got one-to-one sort of care during those 3 to 4 months. So the question was, how can we take this level of support that my friend got to a larger number of people? And I think for me, and there have been other experiences like that, where I'm like, at a one-to-one level, we are able to provide good care, but as a system, it's very hard. Either we do not have the budget, or we do not have enough qualified people to give it to, say, thousands of patients. And that's where, for me, the interest in digital came, because if you look at every other sector, what digital has been able to do is it has been able to take an excellent quality to the masses. I mean, what we are doing now, 10 years back, it was impossible to do a podcast like this. Now you have so many podcasts, and that's all about technology.
Indeed.
So for me, it was, how do you use technology to really scale good quality care to patients? And that was where the interest came from. So.
Brilliant. What a great story. I understand you have a co-founder as well. Tell us how you met your co-founder, and how important has it been to have a co-founder in sort of propelling your company?
I think co-founders are super critical for startups, because it is a very, at least in the early days, it is a very hard journey, because you are alone, and there are certain things that you can discuss with your co-founder that sometimes it's hard to discuss with your colleagues, because they've been with you through the journey. So my experience is that at least have one co-founder, and try not to have more than 3 co-founders, because we had other co-founders, and that really did not work out because we were too many.
Too many cooks.
Too many cooks. So I think my sense is that 2 to 3 is probably the sweet spot. And I think I think co-founder is a little bit like a marriage, because like communication is so critical. Like today, I think my co-founder is based in India, because he's the technology. He leads our technology team, and we pretty much speak every day, at least for half an hour in the mornings. And what we've noticed is that if we don't speak for long stretches of time, it becomes very easy when the company starts diverging. So I think co-founders are very critical, but also like one needs to take due care to make sure that one, you bring on the right co-founder, and you keep working on the relationship, because you work with them for 5 to 10 years, sometimes longer. So I think it's very critical to the success or failure of the company.
No, thanks for sharing that. So you've talked about obviously how hard it is to build a company from scratch, especially in those early days. Tell us what kind of challenges you faced specifically when you were setting up Avegen.
Where to start? That's a big list. I think the first critical challenge for us was, we went in with the hypothesis saying, okay, this product is the answer, or this is what we want to scale. And I think our first 4 or 5 completely failed.
Right.
It just did not pick up any traction. Hardly any customers. So I think there are some problems that probably are not worth solving. And I think, but in hindsight, it's sort of easy to say, okay, you know what, no. So, but when you're looking at it, you're like, okay, this could be the next big thing. So I think that's been probably our hardest thing to get our head around and to manage. Luckily for us, though, we both, Neeraj and I, were very clear that we wanted to build a product-oriented company and not a service-oriented company. So because we had that North Star, we were able to sort of keep our eyes on the goal, saying that, yes, we might do a lot of different things, but what we're trying to build is a product company. So that was one. And second, and I think the credit to this goes to Neeraj, because Neeraj understands, he's a second-time entrepreneur. The first time he was quite successful. So his thinking was that products fail, but platforms don't fail. Because you might say, okay, so what he's always tried to build at Avegen is a platform that and that's where the Swiss Army knife comes, because he's built this platform which allows us to deploy solutions for different problems.
Got it.
So it allowed us to sort of de-risk a little bit and not put all of our effort into one approach, because
a particular product.
Exactly. So I think that's probably been our biggest challenge, and I think the way we have managed it is, taking a very platform approach to the products that we bring to the market.
Yeah, that's brilliant. I've never thought about it that way, that a platform is perhaps a bit less risky than as you say, all eggs in one product basket, as it were.
It's not. I think investors probably don't like it, because for an investor, it's like, they say they invest in 50 companies out of a fund, or 10 companies. They're taking a platform approach, but they are de-risking by investing in lots of them. So ideally they would want us to go after this problem statement, try and make it big. If you fail, that's fine, because I have others that hopefully will pay off. So I don't think, and that's one of the reasons I think we have always had it's been very challenging for us to have conversations with investors, because they want a very clearly defined problem statement that will become the next unicorn. So investors, I don't think like it, but if you're a bootstrap company, I think I feel like it's like a pragmatic way to build a sustainable business.
Yeah, no, that makes perfect sense. Perfect segue into telling us a bit more about the Avegen platform.
Sure.
And perhaps just examples of its use cases at the moment.
Yeah, absolutely. So when the other insight that I had, because I've been doing digital from 2008, so even while I was at the pharmaceutical company, we had done 3 different interventions for 3 different problem statements. One was increasing the uptake of cardiac rehabilitation. That was done by me and my team. The second one was from a colleague of mine who was trying to reduce length of stay for patients who had hip and knee surgery.
Right.
And the third one was by a different team which developed an intervention to improve medication adherence in patients who have mental health issues. 3 different problem statements, 3 different products. What I learned through that was that pretty much all of them have the same building blocks. So you need a backend database, you need an authentication module, you need a content delivery module, you need a clinician dashboard, you need a patient interface. So all of them have the same building blocks. So when we co-founded Avegen, that became our hypothesis, saying that rather than trying to like build a product for, say, diabetes management, a product for cardiac rehab, let's build this platform which allows us to then deploy solutions for different use cases. And over the years, what's happened is that it has naturally sort of converged on what I would say are 3 sort of key solutions. So the first one is remote patient management. So currently at Chelsea Westminster, which is the largest HIV clinic in Europe, what they wanted to do was that they had a cohort of patients living with HIV who are stable. So they don't need to necessarily come into the clinic, very often, maybe once a year. So they wanted to digitize the management of those patients. So using Health Machine, which is our platform, we set up, they call it Click, where the patient through their application can complete, I think once in 6 months, complete a questionnaire.
Right.
That is then reviewed by the nurse at the clinic, and they decide, if the patient needs to come in or not.
Right.
If the patient comes in, they can book their own appointments. So if patient
directly via your app?
Directly via our app. So they come in, the nurse is already sort of prepped because she's already seen what the patient has answered. So then the consultation is a lot more efficient. And then then the patient goes away. If the patient has had bloods, then the blood reports actually come to the nurse. First, the nurse is able to review it, comment on it, and then push it to the clinic. So fundamentally, what they've been able to do is that they've been able to manage this cohort of around 6,000 to 8,000 patients without necessarily having to increase the staff. So the same staff is now managing a larger cohort of patients. So that's what we would call is remote patient management.
Yeah.
Then the second sort of category of solution that we deploy is we call it companion apps. So this is generally for life science companies where for different diseases there might be blocks in moving from first line to third line. So the pharmaceutical company wants to provide a tool to the patient so that they can facilitate the patients moving from first line to second line to third line as quickly as possible, provided it is clinically indicated. So that sort of became the second use case. And the third use case is what we call as digital therapeutics. So these are essentially software products that can be used to treat a specific disease. So those are the 3 sort of use cases that today is supported by the same platform.
That's brilliant. And especially in that sort of final use case, are you a medical device effectively?
Yes. So digital therapeutics are considered as software as medical devices.
Yeah.
The other thing that we have done is that our quality management system we have a fairly robust quality management system, and it is ISO 134875 certified. So even
well done on remembering that number.
It's everywhere. So for us, I think all 3 of them, we follow the same quality management system. So even though RPM and companion apps are not medical devices, but we set it up like it is a medical device. So it's fairly and that's the beauty of the platform, right? Because it's not like we have to follow a different process. Everything is built to a much better standard because the platform essentially enforces that.
Yeah, no, absolutely. And so have you had to go through the whole medical device process in the UK? And I guess, how did you find it? Because I often hear how challenging that process is.
Yeah, so we currently do not have a certified medical device in the market,
Right,
which we are promoting. But what we have is currently we have, I think, 4 or 5 which are going through clinical validation.
Got it.
So for that, what we needed to do was we needed to obviously first figure out the classification of the medical device. Then we had to go to MHRA to get a notice of no objection. And then once the clinical study is completed, then we'll probably have to get it either UKCA or CE marked. The experience is, I think it is challenging. All of us, obviously, none of us want to put out unsafe products in the market. The issue has been that it is such a, one, it is new. Second, it rapidly changes. It's hard. I think it's hard as a system to apply standards to developing software as a medical device, because unlike a physical product, which fairly, like, once it's built this way, it is built this way, it won't change. But with software, because it is evolving, it has to evolve. Like, if Apple or Google changes their operating system, some things don't work, so we have to upgrade things. And I think I think just applying it as is to software as a medical device has created, I think, unique challenges for manufacturers like us. And I think we're getting better. But I think the first one that we did was so hard, because we went to the MHRA. We actually, they rejected, because we couldn't just figure out how to do it. So then we had to go to them the second time. Since then, we've had 2 more, and both of them were relatively painless compared to the first one. But it is quite hard. And we end up having a lot of discussions with academics that we collaborate with, saying that is this a medical device or not? So I don't think we've solved that.
No, as you rightly say, it's challenging, not just because of the process, but as you rightly picked up, that software is constantly evolving. You're adding new features, or you're changing the existing features based on the feedback. It's such an agile market.
Correct.
And an agile product. How do you hold it to account to a certain standard like that? It's a complex process, but I guess, like you say, it's about safety. Correct. At the end of the day. So that's the best that's out there, certainly in the UK at the moment, right?
And to a certain extent, I think the good thing about software is that you can actually respond to, user feedback and user experience, and that's the massive advantage of software. Now, if you apply rules that apply to hardware or even medicines to software, you're actually taking away the best part of that intervention.
And so point.
like why have a static one? Like, if the world is today doing, look at AI, right? Every sector is using AI today. So, but if you have to incorporate AI into a digital health tool, it's so complicated today, because you like, how do you show attributability, like, and so I think we have to find a better sort of risk-based model to regulating digital products. And hopefully the regulators they are, I think, listening. They're trying to make it a bit more, I think, flexible. But I think we're still not there. So
we're some way away.
We're some way away.
Fair enough. So Nayan, tell me, why Avegen? What does the word mean?
Yes, the word is actually is it called portmanteau, where you bring
Oh
together
yeah,
two
yeah,
words
portmanteau, yeah.
of portmanteau.
Yeah.
So Avenir is future, and Gen stands for generations.
Right.
I think it came from this. I mean, I think one day I was speaking to like it was, I think, a 12-year-old, and I was asking him, what does your dad do? And he said, oh, my dad, I think their house help was pregnant at that time or something like that. So he said that, my dad builds things that is helpful for the unborn child. And that sort of triggered this thought, saying that when we, going back to, what's the definition of innovation, a lot of the times I think innovations, I think, really pay off, not just for the current generation, but for future generations. So it was a lot about, okay, as a company, what we want to do is make the world much better for the generations to follow. So that was the whole thinking behind Avegen, saying that, it's for the future generations, not just for this generation. So.
Oh, that's a good purpose to have in life, isn't it? So you've talked about the Avegen platform having these sort of three potential use cases, or certainly what it's developed into. When you go to customers, I guess, how does that conversation go? Is it you who's going to them and saying, look, these are our sort of three pillars. We can also do other things, of course, with the right building blocks already in place. Or do you often find that it's those customers who already have a problem and a proposed way of solving it, and you're kind of the facilitator?
I think it generally ends up being a bit of both. I think as people have come to learn about us, they would generally come to us with a problem statement, saying that, like, I think we had somebody approach us saying that I'm interested in, they wanted to use a digital tool in inflammatory arthritis.
Right.
So they already have a non-digital intervention. They wanted to digitize it. So they approached us saying that, is this something that you guys can do? So a lot of the times, I think people do approach us with a problem statement, knowing that we are fairly decent at tech. And that's more inbound. I think the more outbound is where we are sort of reaching out to, for example, NHS Trust, who we can say, look, we have done RPM for patients living with HIV. Yes. We also know that, this is useful for prostate cancer, PSA surveillance, or for heart failure, or for weight management. And then we say, this is how we can adapt our health machine to your specific pathway. So I think both approaches work. So.
Okay. And just picking up on remote patient monitoring, what kind of you've obviously talked about the HIV use case and potentially prostate cancer as well, and I'm sure there are several others. And with this sort of advent of the push towards care more in the community, etc., it feels like the kind of right direction for most appropriate cases to look at. What kind of outcomes are you seeing, or in terms of benefits for NHS organisations or other healthcare providers who are using RPM?
Yeah. So I think that one, if we look at it from three perspectives, right? One is from a patient perspective, which should and is probably the most important. For the patients, I think it gives them, it's much easier for them to manage their disease, and it saves them a lot of time. So, for example, in the HIV one, I think that they cover a fairly large geography, and patients don't need to take a day off to come in and get reviewed. As long as they are stable, great. And this whole concept of patient-initiated follow-up really works, because in our case, it's the patient who initiates, saying that there's something wrong, I need to have a consult. So I think for the patient, just the quality of life becomes much better. The second thing I think for them has been that having the control over their interactions with the clinic, that's been very positive. So the patient satisfaction is actually much higher when we essentially give the keys to the patient, right? So that's from a patient perspective. From a clinic perspective, it has, at a consultant level, consultants are now handling patients who are more complex. So if an average clinic is 6 to 7 minutes, they can actually spend more time with the more complex needs. And for the nurses, they are now able to operate at the top of their license, right? I mean, some of them are actually doing more clinical care, and it's great for career development and career retention.
As opposed to kind of non-value added.
Exactly.
Admin tasks.
Admin tasks. And for the system as such, what we've been able to do is that we've been able to release capacity that they can use in other places. Like simple things like, previously if they had to cancel or reschedule an appointment, patients would have to call. But if they are on call wait for 30 minutes, they'll just hang up. Now, because the patient is booking, canceling, less appointments are going unfilled. So it obviously leads to savings for the trust and for the clinic. So that's, I think, those have been the key benefits for the three important stakeholders.
Yeah, no, absolutely. And especially with the current push on productivity being quite key,
Correct.
Let's face it, finances in the healthcare system are quite challenged. So there's a 4% productivity target that's been put on healthcare in the recent operational guidance. It feels quite right to be looking to make those types of savings. So you've also mentioned, obviously, the digital therapeutics arm and the companion apps. How would you say Avegen differs from other sort of solutions in the market, which might be very niche? So a specific solution for a specific condition, the products, if you will, out there. How do you differ from them? And I guess why should healthcare organizations work with you?
Yeah, I think the advantage of working with Avegen and Health Mission is that we can actually we can be an enterprise level implementation. And what I mean by that is that I'll take life sciences company as an example, right? Most of them have more than one drug, right? They probably work in more than one therapeutic area. Now, if you go with a niche player and you have 5 therapeutic areas, so then you're working with 5 suppliers with 5 different systems, right? There's a lot of friction that comes with working with 5 different systems. We have pharmaceutical companies we work with them on, they've licensed the platform for 6 different therapeutic areas.
Right.
So there is economies of scale. There is less regulatory and compliance thing that you have to do over and over again.
Yeah.
There's less management overhead. And they're not compromising on the depth of the product.
Right.
Because even for digital therapeutics, our product can stack up against any sort of niche product because we follow the same building blocks.
Yeah.
So I think that's the key advantage. And one of the things that we recently co-applied for a grant with an academic institute is, can we actually just have one sort of patient interface, and then the patient can go in a little bit like how Duolingo does, where you go in, you can pick the language that you want to work on, and you just work on that language.
Yeah.
So that is only possible with somebody like us, right? Because we can support at a trust. I think we've spoken to them about 11 different pathways that we can support.
Right.
So instead of having 11 suppliers, they can work with one, and they then it's worth that extra effort. Otherwise, getting one product live for one department, it's suboptimal.
Yeah.
So
no, that makes sense. And how do you? So you talked about, obviously you match up against any niche product in terms of the building blocks. What about the content, the sort of therapeutic content? Who creates that? And I guess, if I was a niche player, I might be saying, well, I'm a clinician in that space, perhaps, and therefore I know best in terms of therapeutics. So who creates the content? And I guess if it is your customers, who owns that content?
Yeah, excellent question. So I think with digital therapeutics, we actually work with academics. So they actually develop the therapeutic content, right? We don't develop it. If we are launching something, then we would license that content from a university or a research center. When it comes to life science companies, we would generally develop the content because that content is not therapeutic content. It's mostly patient education. And going to your question on who owns it, so obviously when we work with academics, they own the copyright to the content that they develop. If we want to leverage that content for other implementations, then we would essentially license that content.
So potentially in a healthcare organization setting.
Right. Exactly.
And do sometimes, or certainly some of the NHS organizations you're working with, if you have deployed this type of solution for them, do they want to own the content? Does that ever happen? Or create it for that matter?
Create, yes. Own less so. Because most trusts do have patient education content. So we end up either linking to their website or refactoring that content. And also with healthcare providers, I think mostly what they license from us is remote patient management. And there, I think the content is more educational. So there is less, I guess, less interest in really like owning that content. They just want the relevant educational content to be signposted to the patient.
One of the biggest challenges that I often hear from healthcare providers is, sort of buying a solution that doesn't quite seamlessly fit into their workflows. And obviously, you're digitizing quite a part of people's workflows working in these organizations. How do you make sure that is done well and as seamlessly as possible for the staff who are going to end up using it?
So we follow a fairly rigorous sort of implementation approach. So the first step that we do is that we actually understand the pathway that they have, and then they can actually see our health machine is actually quite configurable. So we can adapt it within limits to what the local needs are, what are the stages of the pathway, what are the data points that need to be captured, different sorts of integrations. So we are able to tailor it. But there is that initial sort of setup phase, and then there is training. So we have we call them like a partner success manager who will work and essentially handhold the team through that first phase. And then obviously we do like trainings, then we do check-ins. Generally what we feel is that it's the first, I would say, 2 to 3 months, which is the most challenging, and then it sort of becomes part of how they do it. So that's how, one, from a technology perspective, we sort of tailor it, and the second, we have colleagues who are very experienced in supporting the clinic to get the maximum benefit out of the platform.
Yeah, and that is so important, isn't it? I've seen several absolutely fantastic products go into organizations, and because people are just not using them, or certainly not in an optimized way, the results just don't appear, which you would have expected in theory. So that's so important. That sort of what did you call it? A partner success manager.
Yeah.
I think that's a really good thing to have. And so tell us, how do you measure the success of the platform, and how do you work out that it is being used in that really optimized way, and perhaps share with us any results that you've seen?
Sure. So I think we look at it from, I think, 3 angles. One is the usage. So we look at like depending on what the implementation is. For some of them, it just might be that the patient needs to log in once a month or once in 6 months. So we look at how many of them are active. Then we look at the clinical outcome piece. But that one, I would say, is mostly looked at by the clinic. So for example, with the HIV one, they wanted to improve their adherence to the national standard. So they actually benchmarked themselves against the national standard, and they were able to, when they analyzed it, they saw that, I think that pretty much on every category they had improved their adherence to the national guidelines. And the third part for us is obviously the economic case. What's the cash that we have released, or what's the savings that we have made. So I think for the HIV one, roughly, I think in the first year we were able to generate savings of, I might not be exactly accurate yet, but I think in like 200 or 250,000 or so by releasing capacity.
Amazing.
And so that's 3 angles. And obviously, we look at patient satisfaction. I think they had like a 4.5 on a 5-point scale
Right.
from patients. So those are the ways we look at what impact
Yeah.
it's having on patients and providers.
Yeah. And in terms of the patients using these apps, what is the usage like? Because often I hear about it's all great, patients or indeed anybody else who might be downloading these types of apps. The stickiness is always a problem. How have you found the stickiness of your applications?
I think it's also important to define what is the expected stickiness. So generally, when we look at a problem statement, we try and figure out if it is something that is high frequency, medium frequency, or low frequency. So high frequency are generally where we would like the patient to log in or at least use the app every day.
Yeah.
Medium frequencies maybe once a month, and a low frequency is maybe even once a year. So I think like comparing digital health tools to the social media ones is, I think, a false thing to do. It's not you're not comparing apples to apples there.
Yes.
So we try and benchmark to say, okay, what is a level of interaction that we want.
Yeah.
And in some instances, the program itself is for 12 weeks. Like, some of the digital therapeutics, it is for 12 weeks. So ideally, at the end of 12 weeks or so, we should be telling the user, look, you can maybe use it for another. We are here if you need it. We don't think you need it, and you can uninstall the application. And so for us, in the high frequency programs, we have a very high engagement. So I think in the HIV one, I think we have like 80% of them log in at the desired frequency.
Brilliant.
So it's fairly it's fairly high. But sometimes we also have people who will log in, they'll use it for a day or so, and then they just uninstall it. It does happen,
Of course.
and it is something that I think we have to constantly work at, and also finding the right balance. So for example, we have an intervention, we're currently doing a solution for migraine, and to a certain extent you do not want to remind the patient every day that come log in your thing, because why do you want to remind the patient every day that you have a migraine? Because the disease does not define us.
Yes.
So it's just trying to find that right balance, I think, about being there but not. You want to be a constructive. Your product you want it to be constructive, not something which can lead to distress or anxiety.
Yeah.
So I think, and that's something that we are also trying to like learn and figure out what's the right level of interaction that the product should have with the patient.
Yeah.
While with the healthcare professionals, most of them use it every day, because we want it to be a critical tool that they use.
Of course, yeah.
So I think most of our clinical people use it every day. With patients, I think it's a little bit more nuanced.
Yeah. No, that makes sense. I like your model of sort of high, low, medium frequency, and as you say, the context is what decides how sticky it needs to be. No, that's a really good way to look at it. Nayan, we've talked a bit about obviously the impact that and success of your platform and how you measure it across those different dimensions, and as you say, patients being sort of foremost in that. We hear a lot about sort of patient-centric solutions now starting to come to the market. But do you feel the market is ready for it, especially in terms of, the benefits they can bring, like patient empowerment and literacy, such as your solutions do?
I think the patients are definitely ready for it. I think the patients are seeking innovative ways to manage their health, but I don't think the system is as ready for it, because what we've seen over the last, definitely in the last couple of years, is that innovations or technologies that give the most amount of benefit to the patient have not scaled. They've struggled to get buy-in from the organizations that should ideally be paying for it. And if you contrast that with a market like India, where the patients can actually pay, you see that the patient uptake is much higher, because they can decide, I like this benefits me, I'm willing to pay for this. Here the patient will be like, okay, I think this is good for me, but I'm not sure how to get access to it, because either my trust or my GP or somebody else has to pay for it. I think so there is, I think our model sometimes is the money truly does not follow the patient, if you see what I mean.
Yeah, no, absolutely. And I guess, I mean, it's very true in this space of preventative care.
Yeah.
The government's talked about it. NHS England has talked about how prevention is one of their key priorities. But I often hear founders in the space of prevention talk about how, because there is no central funding, often the uptake is low. So you're absolutely right. I guess, how can we make this system more patient-centric?
So I think it probably has to be a concentrated effort. And my sense is that I think charities will play play and will play a bigger and bigger role. So with some of our sort of interventions, we are speaking to charities where the charities are saying that, our patients need this. So we have to figure out a way to get these to our patients. So I think like recently we had this quite an interesting experience where we had a patient charity representative, we had a representative from a clinical perspective, and then we had representatives from other organizations. And the representative from the patient charity is like, we hear constantly patients saying that the healthcare system does not have enough trained people to support us with what we need this is specifically in fatigue and multiple sclerosis. The clinician backed that up, saying that there is a need for this because we do not have enough people coming through or trained people. The rest were like, oh, we need to get it approved, procurement, all of those things. And the representative from the patient charity was like, no, we have to solve this problem because our patients need this. So my hunch is that over the next few years, and we are also trying to engage more with charities where we can then offer this to patients. We also work with an international charity which is trying to bring these digital interventions to the less the parts of the world that need this but cannot pay for it. So I think patient oriented charities, I think, might be the way to get these into the hands of the patient, and probably less the healthcare providers, which seems a little odd, but I think that's how it's going to play out.
Yeah, it's an interesting point to make, how even though we have what many of us believe is one of the best systems, it's a social system, free at the point of care, and as you say, there's no divide between people who can afford care and those who can't. But has the system become too centered on the return on investment in terms of monetary terms, as opposed to patient outcomes and patient experience terms? And that's the dichotomy that you're describing, which is very true. I mean, we do notice that as well.
And the system is, I think, is a lot more oriented towards like acute events, like COVID. Everything just worked, right?
Yes.
It's not great with preventative activities, because it's like, okay, if I do this, I don't see any in-year cash savings. So the system is not oriented towards that. Like one of the earliest work that I did was in cardiac rehabilitation, which has shown to be beneficial. The quality is great, but there was no funding for it. It would be part of a block contract. So then it essentially became the Cinderella service. So there's a lot of talk about prevention, but I don't think as a system we have figured out how to pay for prevention. So that's why and a lot of the digital tools which are very patient oriented it's more about preventing a crisis rather than treating a crisis.
Yes.
So then you end up in the situation saying that who pays.
Who pays for it?
Yeah.
Absolutely. And if we're going to truly be a national health service rather than a national treatment service, we need to push the focus there, don't we?
Yeah.
Yeah, very interesting point. In terms of sort of working with the NHS, that everybody recognizes it's a complex organization, complex to sell to equally. And you have to jump through lots of hoops, etc. How have you found your journey in working with the NHS?
And I think as an expat, maybe it's much more stark for me because before I came and moved to UK, I thought NHS was one organization. and even now sometimes I can't figure out what it is because and I think and when I speak to founders from outside the UK, and they say, oh, it must be so easy to sell to the NHS because it's a single organization. And I'm like, it is.
Little do they know.
Exactly. It's like a spider web
yes.
where you have, and it's changed. I mean, I've been here only for 15 years and it's changed, I think, 4 times.
yes.
So, and that I think, is the key challenge because every sale to a NHS organization seems like you're climbing Mount Everest.
Yes.
And things have improved. Like, for example, I think the frameworks like G Cloud have made it easier for the contracting part.
Yeah.
But I think what it is not made, it's not helped with what I call like pre-sales or pre-revenue engagement, where you're like, okay, if I have an intervention for weight management, okay, I should, like, this is my path, like these are the people that I need to be in front of engaging with. And I think, and it's so like, even when I first started the company, initially I think I was trying to scale up in cardiac rehab, and within a year and a half, I just stopped. I said, there's no way we can keep this company afloat if NHS is our primary customer. And that's when we diversified and started working with other like life science companies, because we're like, okay, that's at least you can figure out a pattern, and then it's about repeating the pattern. With NHS, I think unfortunately it's hard to at least for me, I have not been able to figure out what the pattern is, so we can't obviously replicate it. So.
And to be honest, I don't think there is a pattern to figure out, right? I suppose I've worked in the NHS pretty much my entire working life, both as somebody who worked on the front line and outside. And every organisation, yes, there are some national priorities, but every organisation delivers them differently. Their funding might be in a different position. They'll have different priorities, partly by virtue of who's at the helm. As well, and their sort of appetite for risk when it comes to new technology and new innovations as well. So it is true, there is no pattern, or certainly even I haven't figured it out. And if somebody has, please do let me know, because and that is why I do find that it is different to every NHS organisation. And as you say, it isn't one organisation. There's several hospitals, and there's several primary care. There's arm's length bodies, all sorts. And then, of course, you've got the big regulator in between. So do you try to sell to them? Do you try to sell to ICSs or providers, or who do you sell to? And who has the funds? And I think that just as important as figuring out the NHS is where is the money, and who's going to pay for it. At the end of the day, you're looking for a product market fit, but who is that market really? You can come up with a solution which changes patient outcomes for the better and all of that. But the question always comes back to, but who's going to pay for it? And it might improve things for the patient, but maybe it doesn't make any savings, like you were saying, in-year savings for an NHS trust. So will they invest in it? And that is a challenging situation for most entrepreneurs who are trying to sell to the organisation. But
I think increasingly, increasingly from an investor perspective, if you go and say that your primary customer base is the NHS, I think they are actually not interested now, because they're like it's too hard. It's not worth worth the investment, which is a shame because it is the largest. I mean, if one could figure it out,
Yes.
a lot of patients would benefit.
Yes.
But unfortunately, it's the truth of the matter.
Yes.
So and it then also ends up being it makes the whole marketplace, it gets dominated by the larger players because they'll be they have the resources and the people to do a lot of pre-engagement work.
Yes.
And obviously the smaller companies, startups struggle because they just do not have the resources or the bandwidth to do, to go out and meet people and just with the hope that sometime in the future, an RFP will come out.
Yeah, and sustaining that is the challenge, and
Correct.
And you're absolutely right. It does feel sometimes that the larger players are always on the table, whatever table that might be.
Right.
Whenever there's a working group being set up at the senior level, whether via NHS England or indeed the government, who's on the table, it's the biggest players, rather than talking to the smaller businesses who are niche, who are trying to solve very niche problems perhaps as well, who are struggling to bring that into the NHS for all the reasons that we've talked about. And what it leads to is a bit of stifling of innovation then, doesn't it?
And it's also what we have noticed is that when we work a fair amount with academics and researchers, a lot of them then just get frustrated. They're like, I remember speaking this statement that one of our partners made. She said, all my work over the last 20, 25 years will be wasted because we can't figure out how to get it to enough patients. And that's it's not a nice thing to listen to, that somebody is actually questioning their life's work because they just haven't seen the uptake that they want these innovations to have. Like vis-a-vis, if you're like my wife is a biological scientist at a pharmaceutical company, and she prides herself on being a drug hunter, and she will if it is successful, she will get the satisfaction that this drug that I've worked on has reached thousands, or even millions of people. And that's what that's what encourages the next generation to say, okay, I want to go out there and discover new drugs. I think when you have people like these 20, 25-year academics saying that, my work has reached, like I've researched, but it's not actually reached thousands of people or the patients in need, then why would anyone else do that? Because they're like, okay, I can do research, but that can't be the end game. Which is a bit disheartening, because you really want these innovations to get to really scale.
Absolutely. And I mean, especially at this stage when the NHS needs it perhaps the most. I hope the right people are listening and and come up with a clever way to do that, because it is a true challenge. And if we're all here for the patients at the end of the day, and indeed, as you say, to encourage that next generation of innovators and entrepreneurs, if all they hear is how challenging it is, will it discourage too many too soon? And that's what we want. Speaking of challenges within the NHS, obviously your platform needs to communicate somewhat with electronic patient records in systems, and that is in itself quite a challenge. The being able to be interoperable with the big players in the market at the moment. How have you either solved the problem or indeed found a workaround to it?
So I think the way we have tried to do it is that we have tried to solve the problem at like 3 levels. So the first one is essentially, fundamentally, our platform is interoperable. So we can send messages, receive messages, as long as it is HL7, we can do that. So that is something that we are able to do. But then we also have workarounds where we can give an export of the data, which can just be uploaded into a different system, or we can also do like use via the Trust Information Exchange or the data warehouse.
Right.
So but at the end of the day, integration is a handshake, right? I mean, you can extend your hand, but if the other person does not lift, then it doesn't work. And there, I think the whole system is obviously very, very oriented towards the big players. And I think with most of them, it's very hard. Like even though they might say that they're interoperable, but the implementation of that interoperability is not very straightforward. So then you have to end up with third-party companies who specialize in integration, and even they sometimes find it challenging. That I think is so. In a sense, I think if you're not a large enough player, then I think it's going to be very hard to scale. One of the things that we also sometimes really challenge our partners on is that what level of integration do you need? Because again, taking this dictum saying that without integration it is not going to take off is again, it stifles innovation. So I think it's about really also challenging them. Do you really need integration, or do you need the data to go into some other system? So I think it's about looking at the art of the possibility rather than just saying, we can integrate. It's not that straightforward.
And equally, I mean, as you say, these NHS partners are always talking about, is your solution interoperable? Is there bi-directional messaging abilities, etc.? But as you say, a handshake is not one-sided. But have you found that those NHS partners then can actually influence these EPR system providers that they might be working with? Because I guess if they really want to be interoperable in that truest sense of the word and integrate and so on and so forth, then they are the ones paying for the EPR system. Do you find that they can influence them to support that conversation?
So they can influence, but I also think that they're slightly hamstrung because the way the big systems operate is that interoperability, if they have to enable interoperability, it comes at a higher cost. So then for the trust, it's a little bit of a difficult situation, right? Because then they have to first find the money to be able to get the whatever they need, the next version to enable interoperability. So I think, and you see that even with trust IT companies, that they feel very hamstrung. They're like, we want to enable interoperability because what you have is what our clinical team wants, but we do not have the funding to get to the next level. So in some sense, I mean, I can see where they're coming from, because obviously they're protecting their turf as a business. But it is very much structured towards, I think, not making it easy. And that's where I feel like open banking, I mean, from the financial sector, it's fantastic. Like, you see pretty much, I mean, as long as you follow certain guidelines, like it's made banking so much more, the data flows, right?
Yes.
Under adequate protection and safeguards. While that does not happen in healthcare. Ideally, you should be having like how you have open banking, you need to have an open healthcare, because once you have data flowing seamlessly, then you can then you actually, innovations flourish in the best interest of the end user. And I think it's actually become harder now with the NHS app, because at least what I've heard is that each system, there can be only one provider who can integrate with. So for example, if Northwest London says, this particular provider will integrate with NHS app, then that's a monopoly, because nobody else can then integrate with the NHS app in that geography. So rather than a one-to-many relationship, it's become a one-to-one relationship. So in some ways, we are embedding one more layer of incumbents, and you will not, I mean, it's going to be very hard for somebody to sort of come in and say, look, I have a new way to diagnose dementia. And it will never, it'll be very hard to scale, because you don't know how to get it into the workflow.
No, absolutely. And I guess, I mean, have you also heard of the Federated Data Platform?
Exactly.
That's come in. And I wonder if the challenges that will come with it are similar, where there's a federated data platform, and yes, ostensibly the idea is, we'll have all this lovely data flowing into it, and people can develop apps on it, etc. But equally, there are lots of native apps that are trying to solve the problems, starting from scratch, not niche, not people who built those types of things from years of experience, but the same provider who's providing the FTP is also building some native apps.
Correct.
And those are being pushed, rightly so, because it's a very expensive platform, as we all know. And I guess I often wonder whether that is also leading to stifling of innovation.
Yeah, I think it's because essentially you're then orienting the whole system to bigger companies, right? And bigger companies have a role to play. They do support innovation, but you're essentially losing out on the grassroots innovation part, because it's becoming increasingly hard for like an academic who has, say, a very good idea. They might be able to get NIHR funding to do some work, but then it just stops there, because like even if they do a spin out, like they can only take it that far. So what you see is, I think you see a lot, including us, we probably do more work outside the UK than in the UK. I mean, there are a lot of companies here who end up going to the US or to Middle East or to other parts of the world, because it's a slightly more friendlier system for I think startup companies.
So. No, that's really interesting. And I guess, I mean, given these challenges, of which we've clocked several now, how have you approached growth in this market? And indeed, you've already mentioned you work with other sort of sectors. But are you still focusing on the NHS, and what is working for you, if anything?
So I think what's working for us is that because we've intentionally sort of diversified our base. In some sense, it's a bit like the rest of our business actually supports our NHS part of the business. I think for us, what's really worked with the NHS, I think, is probably not making friends here, but the frontline staff, the clinicians, are really passionate about improving care. And I think building that relationships with them, the network with them, and then through them then working with the larger organization. It takes time, but that at least will move the needle. Because I think the staff at NHS is amazing. I mean, they're so committed, and that's been our approach. So and obviously trying to do as much top down as possible, engaging with the DHSC, NHS England, being in the right forum, and all of those things, and at the same time really engaging with the frontline staff and ensuring that what we do is supporting them, and then to a certain extent supporting them also to champion it internally. So that works to a reasonable extent. Where we feel it's worth trying to like continue to sort of plug at it. So
is it easier though in the other industries that you work with as well, would you say?
Yes, absolutely. I think because I think because I shouldn't, and it's not that NHS is not a performance driven organization, but in the other industries there is there's a much more shorter cycle. So people want to demonstrate impact, and to a certain extent I think they are also incentivized to take calculated risks.
Yeah.
Failure is not, or rather, the way I should put it is, success is rewarded handsomely. So people with the right sort of attitude do take risks, saying, okay, can I bring this innovation in? If I bring this innovation in and this, if I do really well, it helps me get promoted or go to the next level or have a larger responsibility. So because of that, I think the cycles are much faster.
Yeah.
I think sometimes maybe with the NHS, I think it's a bit, people are less they're risk averse.
Yes, absolutely.
So everything has to be every I has to be dotted, every T has to be crossed, and so because of that, things which should ideally take a few months will end up taking 1.5 years sometimes. So I think so that's I think the key difference.
Yeah, I think that's a really good point around sort of the almost sort of, to be successful, you've got to be able to take that risk. And I think the challenge, certainly from my experience of the NHS, is very much, and somewhat rightly so, they're a publicly funded organisation, so they must have the right checks and balances. So I would never expect them to perhaps match the pace of a commercial organisation. But I think there's something about the cultural sort of space to fail safely. And one of the other founders in another episode specifically talked about that as well. And I think that's so true. The whole system is not geared to help you fail safely and test things out enough, and then talk about sort of pushing it out at a sort of larger scale. Just getting that conversation and then sort of testing your product is really, really hard. So how do we get those innovations to a place where they become evidence-based and then get scaled up within the NHS and all of that? There is I'm sure there are obviously bureaucratic challenges within that, but there is a cultural thing there.
And also because it is I mean, if you like, when we work with life science companies, they're a for-profit entity, we're a for-profit entity, so there is, in some sense, our cultures are aligned, right? But with the NHS, I think it also sometimes feels like there is this perception, there's like, working with the private sector is, it's not super comfortable for them. They're like, oh, you're a for-profit company, so that means I'm not saying it's widespread, but there's this back of the mind saying that, oh, you know what, if they're actually, like, we can get discounts and discounts and discounts, they need to give it to us at a very low cost. So the whole, like, with a for-profit company, like, they're measuring their success as a company by increasing in their top line, bottom line, which is also how we measure. So some sense, you're kindred souls. With the NHS, that, like, there is no revenue to talk of. It's about, okay, can we deliver care at with the budget that we have? So it's a more cost containment model. So culturally, it's also a different mindset.
I think that is such a good point around the cost containment element, and that is not only pushing them to be risk averse, which we've just talked about, but also what we talked about earlier, which is, are they focusing on patient outcomes enough or patient experience enough? Because they're so busy trying to, deliver everything. And gosh, we know how, as you picked up, the NHS is amazing at delivering services and, responds to every challenge thrown at it, COVID being the most recent example. But if they are constantly under pressure of this sort of cost envelope, which, we are there now as we speak, the incentives become very different. It isn't about patient experience and all of that. It isn't about, taking a few risks and to test things out in a safe way, of course. It is all about how can we be saving more money, and, like you say, in year. And most healthcare kind of solutions will take time to generate that kind of return on investment numbers.
And also, like, I mean, with any innovation, I think the first phase, it invariably leads to increased cost.
Yeah.
I mean, because people are not sure. You're trying to sort of understand how this can benefit.
Yeah.
So it actually, in fact, probably will raise the cost before it actually reduces the cost. I mean, when mobile phones came in, it was like super expensive.
Yeah.
Right? I mean, every technology is like that. When
Yes.
it first comes in, you're like, oh my God, this is so expensive. But then as we as humans figure it out,
Yes.
and then the technology becomes better, the cost per unit sort of goes down.
Yes.
And NHS, you just do not have that space, because if they want to buy a new AI-driven tool, like it will probably cost them more in the near term, and then once they get comfortable, they'll start realizing the savings. But they just do not have the space to increase the cost in the immediate term to realize the benefits later, and that I think is also structural to a certain extent.
Yeah. So moving on to I suppose back to your sort of business model. As we know, and with all these challenges that we talked about, certainly in the healthcare side of things, with long sales journeys and so on and so forth, how you fund your sort of health tech enterprise is quite an important thing we all need to be focused on. You've talked about how you're a bootstrapped company. Tell me how you've made that happen.
So I think the way we made that happen, partly I think it was also just circumstances. We started off actually primarily as a consulting company, which was supporting our customers with figuring out digital health solutions, deploying it. And in parallel, we were building the platform. We were sort of trying to get it to a level where we could monetize the platform. And also, I think we actually did some services work, just work for hire, to just fund the build of the platform. And over, I think the first phase, which is probably from 2015 to 2019, I think it was more non-platform revenue. And I think 2019 is then when we really started doubling down. And when COVID happened, it made sales a bit more easier. So, and I think like 22, we probably switched pretty much to platform. So it was a bit of a slow burn. I think we hustled a lot in the first few years. We pretty much did, as long as we had reasonable revenue, we would do it. But the North Star helped, because for both Neeraj and me, we wanted to set up a product-led, profitable, scalable business. So it all made sense, because every penny that you're sort of making was going into building and scaling up the platform. So that's how we have done it. So
great. And so you've never gone out for investment. Is that something that you think you see yourself doing in the future?
So we have tried to raise investment. So we have spoken to quite a few institutional investors, but the thesis did not match, because all said and done, I think investors are looking for the next unicorn.
Yes.
And we thought, and I think from experience, we sort of believe that given the structure of the healthcare market, it would take much longer to get to a stage where the company is quote unquote a unicorn, vis-a-vis the other opportunities that every institutional investor has. So I think we never could agree on a model, and because we were also to a certain extent revenue generating and profitable, the investors were also like, why do you need the investment? So that's how I think it's shaped up, and we've got this far without needing investment. I think the next level, if we do end up getting investment, I think it will probably be less venture funding. It's probably going to be a private equity funding to sort of really scale the company. Are we close to it? No. I think it's just that, I think Neeraj said this. He's like, I would rather work on executing our plan rather than helping a financier execute and show his plan. So, which is
Yeah, which is fair enough.
Which is fair enough, exactly.
And you're now a team of 40.
Mm-hmm.
So, you're no longer a super small micro enterprise, are you?
Correct.
And you've got that all by your own plans, I guess. So
Yeah, I think
that bodes well.
Absolutely. And I think, when I sometimes reflect on it, I feel like we have been able to build a company that can actually, that can deal with the idiosyncrasies of the healthcare space. Like we are not, if we were an e-commerce company, absolutely we should raise, we should have raised. If we have not raised, we should have shut the company down because that's how that market operates.
Yeah.
The healthcare sector, other than maybe for medicines, is a slow moving sector. So we have to have a company that can work, that can sort of succeed in that environment.
Yeah.
And that's what we have done.
Yeah.
So
No, that makes perfect sense. So looking at the next 6 to 12 months, what are perhaps the top 3 priorities for Avegen?
So the top 3 priorities for us is, one, I think we want to double our revenue this year. So that's
Wow.
one. That's one. The second one is that we want our partners or customers to realize the benefits of licensing our platform. So that's the second one. The third one is that I think Health Machine, which is our platform, we want to continue to make sure that it is a platform of choice. So, are there opportunities to integrate AI into some of the work that we do? Some of our customers want it. The other priority is for us to make sure that Health Machine keeps up with the advancements in technology. So things like UI, improving the integration ability. And the final one, I think one of our biggest aspirations for the company is that Avegen is a place that people actually want to join and can really thrive in, and we can attract the next generation. So we're trying to do things that will make it very attractive to come and work with Avegen and say, okay, if you join us, you have the opportunity to build and launch things that can actually improve the lives of people. So I think those are the 3-4 sort of key priorities that we're working on this year.
Yeah, that's fantastic. And I guess looking at the broader digital health space, what kind of trends are you seeing other than AI? Because we know AI is obviously a big one. What other trends are coming that you're excited to hear more about, or indeed sort of perhaps incorporate within Avegen?
Yeah, I think what's definitely happened, I think, is with COVID, there was a pre-COVID, I think most of the system was trying to figure out why digital. COVID answered that question, that we really need to integrate digital, and people became a lot more comfortable with using digital tools. What's then happened is that there's been a little bit of a dip where I think a lot of the big companies or very well funded companies have sort of either folded or have got acquired. So now I think what I'm really excited about it is how these digital tools are starting to get integrated into routine practice. Like you do not want, like I feel like digital healthcare and healthcare shouldn't be like two different things. I mean, it's like digital banking and banking. It's one now. So what I'm really excited about is how, as a system, we are making this part of our daily lives, and that's where I think success is. And obviously, one will inevitably keep up with technology, with AI and other things. It will happen, but we want it needs to be part of the way the system operates. And that's, at least for me, I think for digital health, the most exciting bit.
How you assimilate it quite seamlessly, perhaps for both staff and patients.
Exactly.
Right? Yeah.
Exactly.
Yeah, no, absolutely. And I guess if you could change one thing for the NHS and how they work with innovators or innovative solutions like yours, and more broadly, what would that be? What would you say to them that they could do differently?
What I would suggest to them is that at the right sort of level, so maybe it's at the departmental level, they all do business plans, all do business cases, right? Currently, all of that is oriented towards keeping things just running, right? If there is actually a line item saying that there is a budget item where we will use that budget to try new things, right?
Yeah.
That I think would unlock the frontline staff to say, today when we pitch them, they're like, oh, this is a fantastic idea. How will this get commissioned? And everything gets stuck there.
Yeah.
But if they had the ability to say, you know what, we have, it could be a nominal amount, right? It could be like, we have £10,000 this year that we have set aside to trying new things out. That I think will unlock their ability, and it'll also give them more energy in their work, because all of us do want to try new things.
Yeah.
So if a consultant cardiologist or a nurse, they collectively decide, okay, we want to try like this digital tool, but they do not have to go out and find the budget for it.
Yeah.
Like that, I think would be fantastic. I mean, we were doing this session to increase engagement in the workplace. And one of the ideas that the facilitator said is this concept called no approval required budget. And so we do it now, like where we have a fixed sort of budget every month that our colleagues do not need to get approval from their manager or from me or from the CTO. They can actually use that funding for, to a certain extent, whatever they decide.
Yeah.
And most of the times we know that they use it to do team building or some training or things like that. Because they know what they need.
Yeah.
So I think that concept of enabling the front line to try out innovations, I think could unlock productivity improvement, but also give them the sense that, we can influence our work.
Absolutely.
Today they don't. Today they're like, we have to go here, there, and they just give up, which is a shame. Right?
Yeah, so. I mean that sounds quite amazing. I would have loved that when I was working in the NHS. Just that sense of autonomy, and perhaps that might actually help some really bright people stay within the NHS, because I do think they end up leaving to find that kind of autonomy and being able to influence things, and I think that's so important in your work, isn't it?
The number of clinicians who have reduced their clinical work and are doing like startup, like social media. It's like when I left in India clinical practice, I was one amongst maybe 100 in my batch who took a non-traditional route. Today, you see even people who are training saying that, what else can I do? Like, I don't want to just be a clinician.
Yes.
And that's, you do want to find ways and means that they want to stay engaged and invested in the thing that they have specialized for.
And we know we need that frontline resource, don't we? That's really great advice. Again, I hope somebody's listening. To people who are aspiring to get into health tech as entrepreneurs or founders and have ideas that they want to take forward, what would your advice be to them around where should they start?
I think they should start by really looking at their own motivations on why they want to do what they want to do, because I don't think there are sometimes in like nowadays I think entrepreneurship has in the last 10-15 years become very mainstream because people see growth, people see success stories, but the truth of the matter is most startups fail.
Yes.
Right? So you need a lot of resilience to push through that. So my suggestion would be to really look into oneself, because at the end of the day, when things look most bleak, that is when you have to sort of go back and say, okay, this is why I'm doing it. So I think that's what I would suggest. And maybe the second one is find a co-founder. Like I think it's too hard of a journey to do as a solo. I mean, I really admire people who are solo founders. My suggestion would be find a co-founder who you can really collaborate and work with, because I think there's a much higher chance of success, because you'll be there for each other when things are really grim. So,
yeah. And the pace, I guess,
Yeah.
2 is better than 1.
And you can cover more more expertise areas, right? So,
Yeah.
for example, in us, I cover most of the clinical and the commercial side, while Neeraj covers the technology side. I mean,
yeah.
so like, I don't think we could have bootstrapped if Neeraj was not a very competent technologist and who's based in India, because there was no way we could have bootstrapped if he wasn't there. So.
Yeah. No, that's really great advice. And what about accelerator programs specific to healthcare? So you've obviously been on the Digital Health Accelerator with the Health Innovation Network in London. How did that sort of add to your journey?
I think what it has allowed us to do is really sort of interact with others who are going through the same journey, and people who understand the space, and to a certain extent it also gives credibility to the company, right? I mean, if we say that Avegen is part of the Digital Health London Accelerator, people say, oh, that's good, means somebody has vetted you and you must be good to be part of that program. So I think it definitely helps with building the credibility of the organization, and at the same time, I think just the opportunity to meet the decision makers is fantastic. I think, and that's I think those are the key benefits that accelerators bring.
Yeah, no, absolutely, and obviously, we've talked about how challenging it is in the NHS to adopt innovations. I feel like the more health innovation networks can do in that space, the better. And we're lucky to have them for that reason.
The one thing I think that I and this is a hope and wish, I think, is that accelerators are also a good place for building a collective voice.
Yes.
So, like, for example, with Digital Health London, I think there are so many startups. Because for startups, there is no one who actually promotes on behalf of the startup. Like, there are industry bodies for other things, but not for startups. So I think accelerators there is a gap there.
Yes.
Accelerators could actually, speak to NHS England, DHSC, and say, look, these are the challenges our companies face, and this is what they need if we want UK to have a thriving, innovative ecosystem. And the government is looking for growth, and a lot of the growth will come from startups who grow and flourish and go beyond UK. So I think accelerators could potentially be a very, very strong voice, and I haven't seen too many accelerators actually doing that, saying that they can represent these companies collectively.
No, absolutely, and as you were saying, the benefits of it. Not just for those companies going global and all of that kind of stuff, but just in the healthcare economic case, right? Like, all of these are eventually influencing improved patient conditions, perhaps, reducing our waiting list down, and all of those types of things means more people back at work, contributing to the economy, being taxed and all that, which adds to our prosperity as a country. So absolutely see that point. So thanks for making it. So last but not least, Nayan, my final question for you is, you've had such a varied and wonderful journey that you've talked us through. When you reflect back, if there was one thing that you could change, based on, hindsight, which is wonderful always, what would that be?
I'd have probably started on the entrepreneurial journey earlier. I started it, I think, in 2015. Before that, I was sort of dabbling on the side. I think I should have started, like, the sooner I had started it, the better it would have been. And that's and doing it full time, because I think you to a certain extent you can do it on the side, but you really do not get pace and acceleration if you do it as an add-on. So I think my advice to myself would be, like, take the leap as quickly as you can, because even if you fail, you can do something else. So that is in hindsight, that is probably what I would have done. I think I was trying to get everything organized before I took the leap, and could have done it earlier.
Yeah,
So,
try faster, fail faster,
yeah,
learn
exactly.
faster, I guess.
Because time is the one thing that we don't have, right?
Yes.
It's not infinite.
No, absolutely. Well, that's brilliant advice for others as well who are listening to this. So to definitely take the leap and believe in themselves, I guess. So no, that's a wonderful note to end today's podcast on. Thank you so much for your time and wonderful insights. I feel like I've learned a lot as someone who works in healthcare. As well. So thank you so much for your time today, Nayan.
Oh, thank you. I think these questions also help because you sort of reflect and internalize. So it's been fantastic talking to you.
Oh, brilliant. Well, thanks for coming, and I look forward to seeing you again soon.
Thank you for listening to this episode. And if this is the first time you've joined us, do go back and check some of our older episodes because every story has something to offer if you're interested in the healthcare space and the innovation space. And of course, don't forget to subscribe to our channel for future episodes. Thank you for joining us today once again, and have a lovely day.